Welcome to video 7 in the Safe Recovery Training Program, in which we discuss Framework 4, Getting Staff Engaged with Falls Prevention Activities. I'm Professor Terry Haines. The objectives of this video are to understand why staff may not engage in falls prevention activities and to learn some strategies to help staff engage in these activities. As I've previously stated, assistance from hospital staff to patients to be able to perform activities is critical to ensuring the safe recovery of patients while in hospital, and that facilitating this is a key aim of the Safe Recovery Program. Now, in some of the research that we've done in the past that I've already alluded to and provided references for, like this paper here, They Will Tell Me If There Is a Problem, we've been able to identify the various roles and responsibilities that health professionals take upon themselves in relation to falls prevention. And what we found is that it's very much a siloed approach, that medical staff do very medical things, that nursing staff focus on very nursing related issues, and that allied health focus on things such as exercise and mobility prescription, and that there doesn't seem to be a huge amount of collaboration between these silos. What is common amongst all staff, though, is that they feel limited in falls prevention by not having enough time. There are many competing tasks that they face and have to address each day of their work beyond falls prevention. Staff often follow formal procedures and informal procedures. When I say formal procedures, I'm referring to things such as following guidelines, things that are written down, having to complete risk assessment tools and such. And in regards to informal procedures, these are practices that may not necessarily be written down, but by convention, by modelling and by pioneering of individuals on a ward, they're practices that are just done, they're routines that are done on a particular ward, even though they're not written down anywhere that they need to be done. Now, some staff do feel empowered to go beyond these formal and informal procedures, and some actively problem solve issues related to falls prevention for their patients. However, this will vary between wards, and I've also found that it tends to vary depending on the employment status of the individual staff member. Many wards engage casual staff members or very part-time staff members who are quite often confronted not only with a large workload, but also having to adapt to different work environments, new systems, new paperwork, and many other factors when they come onto a ward to perform a shift, and that to be able to go beyond this is asking a bit too much for the individual on that particular day. We've found that medical staff commonly view falls prevention while in hospital as the responsibility of nursing and allied health staff, such as physiotherapists and occupational therapists. They commonly report that they provide post-fall reviews if someone has fallen, and this is quite commonly in line with formal procedures, policies, and standard care conventions. Some report trying to address culprit medications while patients are in hospital, although often very junior medical staff are the ones involved with the direct day-to-day care of patients, and patients and medical staff often don't want to mess around with a medication regime that may have been set up for a patient by their general practitioner if the patient is only going to be spending a short time in hospital. Allied health staff, such as physiotherapists, engaged in providing mobility prescriptions. So this is when they come, assess the mobility of a patient and say, right, you can only walk this far and you need someone to assist you, and you need to use this particular gait aid when performing this activity. They're also responsible for providing exercise and rehabilitation opportunities, which are very important for older adults in their recovery and in their ability to test their physical boundaries in a supported way. It must be noted, though, that particularly in the acute setting, not all patients are seen by allied health staff, and their input is often limited. Therefore, this can limit the availability of appropriate equipment and gait aids to some patients. It may, of course, vary from hospital to hospital as to what the role of these allied health staff members is, and in some hospitals it's nursing staff that take on those particular roles. You'll recall Framework 1 relates to the ability and demand that a patient faces when trying to undertake a particular task while in the ward. We can conceptualize the role of the allied health staff in terms of enhancing the ability of the patient by providing aids so that they can undertake certain tasks more easily, and also provision of advice to avoid difficult activities such as going to the toilet on their own. This can affect the decision making of the older adults through this direct instruction, and therefore lead to a reduced demand of the activities that are actually attempted. We found that nursing staff commonly agree that falls are a problem, though some indicate that there is little that can be done to prevent falls. Many would like to do more to prevent falls, but their competing tasks limit their capacity to spend time trying to prevent falls. Often falls are seen as a bit of a flavour of the month, but that this is interchangeable with other areas such as pressure areas, continence, medication area reduction, and these can all compete for attention in the mind of the nursing staff member. Nursing staff are often stretched by patients with delirium, dementia, or those displaying other risk-taking behaviours. So they may search for strategies that improve safety and free up some of their time. This is what we commonly see in a number of falls prevention initiatives, such as the use of bed and chair alarms. Ronald Shaw is a medical practitioner and accomplished researcher in the United States who has a wonderful research unit there focused on preventing falls in the hospital setting and improving care in amongst the Veterans Affairs population in Florida. He conducted a cluster randomized controlled trial across 16 medical surgical units that was very large, and used proximity alarms with team prompting to increase their use. He also used trained evaluators to go around and look at the falls in the medical records and to check off against incident reports as well. Unfortunately, he found that use of the bed alarms, the proximity alarms on chairs and beds, did not reduce the rate of falls in the intervention group before the study compared to after the study more than the control group, because there was a similar reduction there. And indeed, the rate of injurious falls before the study was the same as after the study for the intervention group, but for the control group there was a fairly sizable reduction that wasn't seen in the intervention group. So from this study there was no benefit from using the bed alarms or the chair alarms on the rate of falls. A similar study was undertaken in the United Kingdom and recently published in Age and Aging. Apinda Sahota led this work and found in a similar way that use of the bed alarm did not reduce the rate of falls or the rate of injurious falls in the intervention group compared to the control group. Another intervention which has been used to try and free up staff member time and reduce falls has been the use of low beds. And this is one of my previous studies that I conducted while I was working in Queensland with Rebecca Bell and Dr. Paul Varghese. And we had a range of low beds that we provided to hospitals across Queensland, and we did so in a manner that allowed us to conduct a cluster randomized controlled trial. Unfortunately, we again found no difference in the rate of falls between the intervention and control group when comparing the pre- and post-intervention fall periods. So all of this makes me wonder about the concept of risk compensation by staff. Risk compensation is something that we've discussed in relation to patients already, but it is also possible that staff members engage in risk compensation. So if I pose the question, if a person is being nursed in a low bed or a bed with an alarm on it, do I need to spend as much time supervising that patient? And to me this question is insightful as to the results of the trials that have been conducted in low beds and bed alarms, that perhaps these interventions are better at freeing up staff time than they are in preventing patient falls. Now, moving forwards in this area, I want to introduce now the COM-B model, which I previously discussed as a means for understanding health behaviours. I'm going to use this model to try and help explain in a very simple way things that might enable a staff member to engage in a behaviour that will promote the safety of their patients. In the COM-B model, as developed by Susan Mickey, it is the combination of three key factors: capability of the individual to perform certain activities, the motivation of that individual to undertake those activities or behaviours, and the opportunity presented by the environment and systems in which that person exists, that all interact to enable the behaviour to take place. So if we look at staff actions to prevent falls in framework form, the first thing that I want you to consider is the motivation of staff to try and prevent falls. And this can be influenced by their awareness of the problem of falls, their knowledge of falls prevention strategies and risks, and also their general attitudes towards falls prevention. Strategies that might be useful for trying to address these issues, if they're found to be lacking in some areas, will be education and training of those staff, information provision, and discussion with those staff about the problems that exist on the wards. Again, in my experience, most staff are aware of the problem of falls. Most staff agree that they are preventable and that they are motivated to try and do something to prevent falls. They feel that they just don't have enough time to try and do so. But it's possible that you might encounter a set of hospital wards that has a problem in these areas, and that some educational training might be required to try and address this. The influence of equipment and decision supports. By the term decision supports, I'm referring to things such as falls risk screening tools and falls risk assessment forms, mechanisms that assist staff to consider the issue of falls. All these things are formal procedures normally, but also equipment such as lifting hoists, walking aids, and their availability on the ward are also other factors that enhance the opportunity of staff to engage in activities with patients that might reduce the patient's risk of falling. Other local formal procedures may relate to when patients are toileted, the order in which patients are taken to a particular dining room or taken back from a particular dining room, may all impact on the rate of falls in a particular location. To change formal procedures, you need the input of leaders and management who have the authority to be able to change these procedures. So when looking for strategies to try and enhance staff actions that can be related to the provision of equipment, decision supports, or following of formalised procedures, you'll need to get the leadership of a particular ward on board to be able to make changes in these areas. There may also be local informal procedures that are followed, and they're very much more influenced by the actions of peers or other local leaders, although getting ward management on board is usually a good idea as well. But critically, it's the availability of time that is going to be the most important thing to many staff members, for them to be able to take some strategies, take some actions aimed at preventing falls on their wards. Now, one of the things I do want you to consider is that the provision of falls risk assessment tools and other informal procedures and formal procedures might impact upon the amount of time people have available to prevent falls. If we take the example of a comprehensive falls risk assessment tool, there's been no evidence, no consistent evidence I should say, to demonstrate that using comprehensive falls risk assessment tools in the hospital setting actually reduces the rate of falls. But it is very clear that it takes staff time to complete these forms. This is time that could be spent at the patient bedside and being engaged with other activities that might reduce the patient's risk of falling more effectively, such as having a discussion with the patient about how they want to go about getting to the toilet. Trying to reduce competing tasks then is one of the critical things that we need to do to try and enhance the amount of time available to prevent falls. If there are things within our control related to falls prevention that are easily manipulated, then great, try and address them. However, other tasks, it's certainly going to need the input of local leaders, peers, and local management to try and eliminate some tasks that are not being as productive as what they could be. Finally, I want to raise the factor of interactions with a patient. Now, the nature of a relationship between staff and patients on a ward is quite unidirectional. Often staff tell patients how they are to behave, staff tell patients what they are and are not allowed to do, but this relationship could be bidirectional. Patients could tell staff what their desires are, what their preferences for care are, and in fact many hospitals now advocate for patient-centered care models that espouse this very virtue. However, how often do we take the time to sit down with a patient and ask them, when would you like to be showered? When would you like to be toileted? When would you like me to come in and check on you? Because patients may have requirements that are not predictable, such as being able to get a book or get the TV remote that some family member had left out of their reach. If the patient knows that every half hour or so a staff member is going to check in or walk by, that they will be able to get that assistance, then they're going to be less tempted to try and perform that activity on their own. Whereas if they're left on their own for greater periods of time during the day, that they may be much more tempted to try and perform those innocuous activities by the bedside that can often lead to falls on their own. Trying to encourage patients to initiate this interaction with staff members is one of the things that we can certainly do as a part of the Safe Recovery program. And again, it's one of the things that we've found in our qualitative research very rarely happens. Patients take a back seat and they assume that staff will tell them if there is a problem that needs to be addressed. Rarely will patients take the initiative to discuss with staff what their desires are unless they've been empowered and encouraged to do so. And that is something that we can do as a part of the Safe Recovery program.